So first case will be if a patient comes with COPD, what we gonna do? First of all, we will give him oxygen and elevate head pad. We will attach cardiac monitor, pulse oximeter, IVSS. Then we will do the examination. Then we order pulmonary function test, chest X-ray, IBG, EKG, CBC, and BMP, which is all patients. Then, then what we are gonna do? So after these things, that we because he's like we know he has a history of COPD, then we give albuterol nebulizer. We can give patient nebulizer if he is like having difficulty. Then when you will advance for the result, you will see patient has low pulmonary uh, low oxygen saturation, abnormal chest X-ray result, then you can give you assure that he has COPD, then you will give protropium nebulizer, IV steroid, methylprednisolone, oral IV antibiotic. It depends, and then you advance the patient, and if patient improve, then you counsel him. Influenza vaccine, pneumococcal vaccine is like acute exacerbation of COPD if the patient has. So this is a general approach of COPD. So what are the general approach? Okay, you have to give inhaled oxygen, nebulize albuterol, protropium, steroids, IV steroids. For his exacerbation, we give IV steroid. For response to oral steroid, inability to take oral medication, then you can give IV. Empiric antibiotic, if you see if the patient has like infection, ESR is elevated, then you can give outpatient. If the patient comes in outpatient, then trimethoprim or doxycycline. If patient is inpatient, then we give respiratory fluoroquinolone, levofloxacin, moxifloxacin, or ceftriaxone or ceftriaxone should be given. Sputum gram stain in moderate severe cases. Only if empiric antibody does not work, then we have to test for sputum gram stain. Non-invasive positive pressure ventilation in PCO2 is greater than 45 and pH is less than 7.30. Mechanical ventilation in ICU in cases of severe respiratory acidosis, respiratory distress, hypoxemia. What are the indications for hospitalization for COPD patient? Marked dyspnea, inability to eat or sleep due to symptoms, increased hypoxemia, increased respiratory acidosis, and mental state, inability to care for oneself, presence of comorbid, pneumonia, cardiac arrhythmia, congestive heart failure, diabetes, renal failure, failure outpatient management. When a patient if patient condition improve, like pulse oximetry, pulmonary function improve, then we will transfer the patient from emergency to ward, convert steroids from IV to oral, convert albuterol and protropium from nebulizer to meter dose inhaler, meter dose inhaler dose, assess for home oxygen. We have to prescribe home oxygen if the patient PO AO2 is less than 55 and saturation is 88, less than 55, 88. And what we are gonna do if a patient comes with acute exacerbation of bronchial asthma, same thing. Pulse oximetry, oxygen, IVSS, head evaluation, cardiac monitor. Examination, same test, same treatment regimen, just like we did it in COPD. We have to do pulse oximetry every 1 hour and same. And you have to follow up the patient for general and lung examination. Um, And if the patient is not, if patient comes in office for prognostemia and he's not improving, then you have to shift him ward. And in the ward, you have to, now it's in ward, we have to NPO, IV normal saline, complete bed rest. We have to monitor B flow. And after the patient resolves, then you can give him normal diet, ambulate at will if the patient is good to go home. So it's the same management for both bronchial asthma and COPD exacerbation. If a patient comes with what we call foreign body. If a patient comes with foreign body, first we have to see it's partial or non-partial. Partial mean there will be presence of speech or cough. Non-partial complete mean absence of speech or cough. If it's complete, then you have to perform back blows and chest thrusts. Back blow and chest thrust in infant and Hamlet in older children. अगर partial है, if it's partial, then you have to avoid back blow and chest thrust because and Hamlet as they convert partial into complete. You have in the partial you have to administer oxygen, perform chest X-ray, neck X-ray. Jimmy assists us in diagnosis if the patient has foreign body or epiglottitis and other causes in children. Be aware negative X-ray do not exclude foreign body as most foreign body ingested by children are radiolucent. Perform rigid bronchoscopy even in setting of negative X-ray. If suspicion of foreign body, high rigid microscopy is diagnostic and therapeutic. IV antibiotics or IV steroid may be if there is infection or inflammation. Then you do bronchoscopy and counseling in this patient. You monitor the patient with cardiac monitoring and pulse oximetry. Send the patient home and schedule an appointment monitor week and counsel the patient and reassure the patient. This is foreign body aspiration, bronchial asthma. Now we will see one case of croup because it's also infectious. Mm. So if a patient comes with croup-like symptoms, what you have to do? First, you have to like, is this mild or moderate? If it's mild, it'd be like barking cough only, no stridor at rest, no restrictions, only cough. You have, will provide him cool humidified mist and oxygen, which relieve airway edema and decreases viscosity of mucus. Monitor for development and bronchospasm, susceptible children, oral dexamethasone you can give. Moderate to severe, yeah, is means stridor at rest. Moderate to severe retraction, anxious, agitated patient. Add nebulized epinephrine. Be aware of tachycardia because of epinephrine. If no improvement, then you can admit the patient. In all cases, if bacterial infection is suspected, antibiotics add करेंगे. You will add the antibiotic second generation cephalosporin and arrange the patient outpatient follow up. So we have done these four cases. Now we will do cardiac scenarios, some cardiac scenarios.